Thank you all. I'm so excited to have you here to hear about this work. The name of our project is Promoting Rural Health Equity Through Community Engagement. So as Claire mentioned, Randall and others actually brought to our attention that our state is fast outstripping our neighbors and other states in the country with the loss of rural hospitals. Could we have the next slide, please? And so the Tennessee Healthcare Campaign decided to approach this issue in a systematic and conscientious way as possible, but building on the experience and knowledge of our community partners. So the key partners as we designed the project were the Healthcare Campaign, our members, our board, and our staff, and Vanderbilt University, both the medical center and the university itself. We received 2 small grants through the Vanderbilt Community Engaged Research Corps, which supported the expense of bringing community people together to have a lunch and to receive a small honorarium of $50 for talking with us as part of the listening sessions I'll tell you about in a minute. Next slide, please. So as Claire mentioned, we had a pretty impressive team. Still, we have an impressive team. I'm not going to go through descriptions of us again, except to point out that in our team, one of the things we think made the program and the process of doing this so enriching for us all was the diversity. So we had Randall and Velma, whose roots are in West Tennessee and the western part of the South. Tracy brought the perspectives and connections to East Tennessee rural community members. Rich has a long history of community activism in East Tennessee as well. And Leah and Catherine, our 2 graduate students working with Velma, brought the academic rigor that we needed. And so we felt like that's really what makes a community research project gel. Not only do you have to have representation from everybody, but you have to have people doing it who are willing to go the extra mile, who have a good sense of humor, who will stay up late when needed to make something happen. And we just had the most wonderful group. We also had a few other people who have come in and out, other board members who've helped us out, and we want to express our gratitude to them as well. Next slide, please. So we began spending a bit of time trying to figure out what exactly are we going to look at, recognizing that in order to resolve a problem, you have to have good, clear questions to start with and agreement on those questions. So the first question we had is, why are so many rural hospitals in Tennessee closing? What are the factors that are contributing to that closure? Are those factors at the community level, the state level, or somewhere else? So what's the reasoning? Then the second question, and we haven't finished answering this yet, but we're on our way, is what strategies at the community level can help communities in Tennessee or anywhere around the country continue to provide health care even with the potential loss of a hospital or the loss of a hospital. Next slide, please. Because we're a community-based organization, our focus has always been that our main responsibility is to citizens and communities in Tennessee. And we decided that the best product we could focus on would be a toolkit that could be provided at no cost to communities in the state or potentially other states who either are about to lose their hospital, are afraid they will lose their hospital, or who have already lost the hospital. So we began, once we had our questions resolved, to talk about what might we include in such a toolkit. And you can see on the screen, these are the basic components of the toolkit that we're just about finished with and just about ready to post on our website. But the first one is how to know if your hospital is vulnerable? And then why do you have to act right away at the community level? What strategies might be available to prevent a closure? And then if your hospital does close, what are your options? What's the role of government, and what's the role of local nonprofits? And what can the state and federal government do to help this situation? Next slide. So we put this slide into our presentation just to show you that this is certainly not only a Tennessee problem. If you look at this map, all of those blue circles are places where hospitals have actually closed in the last 10 years. So it's all over the place. Now, Tennessee ranks #1 per capita, but Texas has a lot of closures. It's just they have more people. And closures are an issue really all over the country. The yellow circles are places where what was formerly a hospital has been converted to some other kind of health facility. And that can be a good thing or not so good a thing. It depends on what kind of a facility is created. Next slide, please. So this is a map of Tennessee counties, and I know it's hard to see the names of the counties, but if you look at those red circles, those are the places where hospitals have closed permanently in our state since 2010. And you can see those red circles stretch all the way on the west from, I think that's Gibson County, to the east, Washington County. So it's all across the state. It's not just Appalachia, it's not just West Tennessee, even in Middle Tennessee, rural counties have permanently lost their hospitals. Now, the black circles are places where there's no emergency department either. And even if you're not that familiar with the issue of hospital closures, it's just common sense that you want an emergency facility in your county, no matter where you live, in the case of an accident, a stroke, a heart attack. So the places where the black and the red come together are where we've lost a hospital and there's no emergency department anywhere in the county. Okay, next slide, please. So we set out basically with 3 big methods we decided we would use. The first one, we wanted to listen to people in rural counties in the 3 different regions of the state and ask them, why do you think your hospital closed? What was going on with the hospital before it closed? What kind of cooperation did you receive from people in the community or the state, etc.? So we structured listening sessions for 6 rural counties, and actually as we did it, we had representatives from more than 6 counties participate. But that was our first key method. The second thing we did was interviews with key stakeholders who were not part of the listening sessions. So these interviews included hospital administrators, community activists who have been working on this issue to help give us some depth to add to what we were learning from citizens. And then the third major method we used was a comprehensive literature review of rural health around the country to look at what's happening in other states with other hospitals and other health policies that are addressing the issue of rural health disparities. Next slides, please. So getting back to the listening sessions, all told, we spoke with 40 different people. Many of them were county government workers or first responders. We spoke with a number of health providers and hospital administrators and board members. And then we were very pleased that we had so much engagement and enthusiasm in the groups from business leaders who could recognize the relationship between the economy in a rural county and whether or not there is a hospital present. Next slide, please. So I'm going to hand this over now to Leah Branham, one of our graduate students, and let her talk with you about the profiles.
Thank you, Barbara. So as a part of our listening sessions, our team created the county health profiles that you see here as infographics that contain lots of different data and information on both economic and social determinants of health. And these were based on our research of indicators of health outcomes, as well as financial viability of hospitals for communities. And these really served within the listening sessions as a conversation starter around risk and protective factors that communities were experiencing. Next slide, please. So on the first page here, we have, of course, demographic data from the county, and including health outcome and even health ranking data that would be a complement of the Sycamore Institute that really just showcase what a community is currently experiencing in terms of health outcomes. And then we also included several data points around hospital access, of course, whether or not a hospital exists in the community, whether there's been a closure, emergency department, and then distance to care, which are all components that greatly impact a community's health outcomes. Next slide, please. And then on the back page here, we have employment data, particularly the main industries in each county. And this data is important both for assessing economic health of a community, as well as insurance coverage. And then additionally, we know that some types of manual labor contribute to chronic health conditions for individuals as well. We have several points of coverage and poverty data that indicate whether or not there's a great ability to pay for health coverage within a community. And then we have in the blue box here, hospital utilization data. And these are all different data points that indicate the financial viability of a hospital. And then finally, at the bottom here, you'll see a graph based on joint annual reports. It includes expenses, revenues, assets, and liabilities over a 5-year time period. And we used this as a way to introduce communities to a mechanism for assessing the health of their local hospital and to see how that can change over time. And ultimately, these county health profiles really served as a way to start to discuss with communities who might be affected most by a hospital closure, who might be most vulnerable, as well as some warning signs or indicators that a hospital might be at risk. And so now I'm gonna turn it over to Randall on the next slide so he can discuss with you all what we learned from the listening sessions.
Sorry about that. One of the glitches of doing Zoom is you got to learn to unmute yourself when it's your turn to talk. So next slide, please. As some of the things that we learned as we traveled around the state and visited with communities is that the profiles of the rural communities, the patients they have, typically they're older, they're poorer, and they're sicker. They're less likely to have employer-based health coverage and more likely to be on Medicare or Medicaid. They're also more likely to be uninsured at all. Next slide. Tennessee rural hospitals, we've learned that they have the highest rate of closure per capita in the United States. They have fewer privately insured patients. The facilities typically are older, and the equipment is also older and more costly to maintain. And they have difficulty recruiting and retaining medical staff because they want to be in the big city where the big money is quite often. Next slide. So what happens when a rural hospital closes? In our tour around the state, listening to or holding focus groups, our main purpose there was to listen to the people that are actually affected by a closure or a possible closure, and to hear what they had to say. The research, the data can be found, but we thought it important to hear the people that are actually living with this problem. Next slide, please. We learned right off the top, and it was everywhere, that the first responders bear that extra burden when a hospital closes. We heard in more than one county where they would say our county ambulance became our emergency room, because there was no emergency room and no hospital nearby. So emergencies, that county had to do more training for their EMTs. Some of them had to become paramedics because there wasn't a doctor. We also learned that once the hospital closed, the distance to the hospital now became, instead of a 10 to 15-minute ride, it became a 35 or 40 or 50 mile away ride, sometimes over mountain roads. That meant that the golden hour.
And sorry, I don't mean to interrupt you, but it sounds like there's some papers being shuffled and it's getting a bit difficult to hear you.
Okay, let me do that. Distances. Is that better, Allie?
Yes, thank you.
Okay, the distances became stretched out from a 10 or 15-minute ride. They became 35, 40, 50 miles away in a lot of instances to get someone from the town where they are to the town where the emergency room and the hospital is. Quite often that's over crooked mountain roads. So what that meant was that the golden hour to get treatment is now beyond reach in some of these places. That meant that an EMT was no longer enough. We heard local government leaders talk about how needing a paramedic on an ambulance due to the long transport times, which meant more expense for the community. We heard a policeman ask, do you know what it feels like to watch someone die because all you know how to do is CPR or apply a tourniquet? And the policeman was put in this position because the ambulance and the crew were already helping someone else. Due to the longer turnaround times, more ambulances and staff are needed, and the budget simply doesn't allow it. Sometimes when an ambulance is needed, it's just not available. Next slide, please. Healthcare providers, we heard from them, and a lot of their complaint was they lose key supports. One provider commented, when you have to send our patients an hour away to get x-rays or lab work, the CAT scan and other diagnostic tools the hospital providers are now gone because the hospital's gone. Specialists are now several counties away in some instances, and they're hard to get to. Then hospital patients need the support of the family. And it's a struggle sometimes when the hospital is 2 counties away for poor families to get there and be with those patients. Next slide. Community residents, we heard from them, they're worried. They said, how do you handle injuries when a tornado comes through or a school has a safety event? There's no hospital, no emergency room. What if a child has anaphylaxis or a serious asthma attack? I heard from one father that was very concerned. His son has serious allergies, has to have an emergency room almost immediately when he has a problem. He told me that if the hospital does close, he has to move. He don't have a choice. The remote recreation areas. A lot of these counties that are rural, they're a long ways away from the big city. They're recreation areas, they depend on tourism. And tourism depends on emergency medical care when accidents happen. The poor, without good transportation or funds to travel, we heard about them. When the hospital is gone, people with no insurance and folks with chronic conditions and families with special needs have a new problem to deal with, because now they have to go a long ways to get the care they need. Next slide, please. Businesses, we heard from business people. Businesses suffer when the hospital closes. We heard from one businessman. He said, when you take 150 jobs out of a small county, it has an economic effect. This county had less than 10,000 people, and the jobs are some of the best jobs in the county. The effects ripple through the community, affecting everyone. The owner of a McDonald's could tell the difference because sales switched from more expensive items to the dollar menu. When the hospital closes, the difference, because sales, the difference is that displaced employees go somewhere else to work. They do their shopping in the other place. They buy their gas, their groceries in the bigger town where they work instead of coming back home to the hometown to shop. School enrollment's down. That means that state support is down too. Pharmacies are having a hard time. When people go somewhere else to the doctor, they also get their medicine there. Real estate sales, a number of them were reported to have fallen through because retirees and others, they no longer want to live there without a hospital care being available. Next slide. One of the often heard complaints is that communities are blindsided. It's a secret almost when a hospital is being planned to be closed. In one focus group, a member said, I was chair of the hospital board. I got a call at 6 p.m. that evening that there needed to be a meeting at 7 o'clock the next morning, and they were told the hospital was closing. Similar comments were heard from more than one mayor, hospital board members, and community leaders. They did not know their hospital was about to close until the last minute. They had no opportunity to prepare or try to avoid the closure. We heard about remodeling and other expenditures, even hiring staff just days before the closure announcement. It was believed that the efforts were to hide the impending closure. Next slide. Finally, the local economy slows down. We heard from one county, the rural county, and it depends on recreation. And the rural communities, especially those areas, they're attractive to retirees, but not if there's no hospital. When making their decision whether to move there, they check, and if there's no hospital, that deal falls through. Businesses looking to relocate, if there's no hospital there, they mark you off and go somewhere else. Younger people don't want to live in an area without obstetric and emergency pediatric care, so they go somewhere else too. And so from all of this, the local community suffers from lack of health care, economic growth, and possibly regression when the local hospital closes. To discuss our policy recommendations and resources is our team member, Tracy Stansberry. So let me hand it off to her.